But, we're the most trusted profession, and patients really get in tune with us. And if they feel safe with the nurse, they really start to feel safe within the healthcare system. And you can really tackle a lot of that feelings that patients can have and the worry that they have by just being there for the patient. And it's something that is so powerful as nurses that we sometimes forget we have that power.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with Beau Amaya, Associate Director of Patient and Caregiver Education at Memorial Sloan Kettering Cancer Center in New York, about nursing considerations when caring for LGBTQ+ patients with cancer. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Beau.
Hi, thank you. I'm pleasure to be here.
So to start, I think we can say, somewhat oversimplified, but important to say, that words are important. Words matter, and the language that we use matters when caring for patients. So let's talk a little bit about the language we use when caring for patients in this population. Can you briefly help to explain the difference between the terms that we often hear used, sex assigned at birth, sexual orientation, gender identity, and gender expression?
So those are four major components that really makes a person's identity. So I think most people know what sexual orientation is. So sexual orientation is someone you could be attracted to, who you may want to be with. Common terms for sexual orientation: straight, gay, lesbian, bi. There are others, but those are the general terms. When we look at sex assigned at birth, I think that's probably one of the most important when we're looking at health histories, cancer screening, cancer issues for patients. Really, sex assigned at birth is what a person is assigned when they're born. So it's really what is their perceived gender, their perceived sex when they're born. So most people are male or female, but some people, actually there's another sex, or would be considered intersex, who may have ambiguous genitalia or may have both sex chromosomes and such. So it's not always just male or female, but when we're looking at sex assigned at birth, that is really what the doctor assigns the child when they're born. The next is gender identity. That's your personal internal perception of your gender, how you feel on the inside, how you feel who you are. It's really not visible to other people. It's how you feel on the inside. Most people in the world, I think, identify as man or woman or male or female. Some people identify as non-binary or outside of the gender binary. And that is more and more, we're learning more about that. And then we have gender expression. And what gender expression is, how you express your gender to other people and how other people perceive you. So it's what you're showing to other folks. So I myself am a gay man. And oftentimes at work, I'm dressed, with a shirt and a pair of pants and a pair of shoes and a belt. I'm presenting more masculine. But, maybe if I'm out with my friends or during gay pride or something like that, I might dress a little bit more feminine or wear more traditional feminine colors. And my gender expression may be a little different depending on the situation that I'm in.
Great. Thank you for providing those definitions from the beginning of our conversation. And I think it's important for nurses to spend some time to understand the difference between those terms so that they can become more comfortable using them and using them appropriately so that we can be clear on the information that we're seeking from our patients. Along those lines, can you provide maybe some specific examples of when nurses would use these different terms in their interactions with patients or during clinical practice?
A lot of these terms, what we call is called SOGI data, or sexual orientation, gender identity. So you may see some of that acronym within some of the medical research or some things you can read about different LGBTQ issues. But one thing about when you're talking to patients about this, sex assigned at birth can be really important to understand when taking care of patients, especially when they're going through cancer treatment. So when you're getting SOGI data is important because it really tells you the history and what's going on with the patient. So some patients may identify as a woman, their sex assigned at birth may be male. So there's a difference between there. So the patient may be presenting as a trans woman, a woman. You're not seeing their full health history because you may not know all of the different information about them. So sex assigned at birth is really important to know really the full medical history and what the patient is really needing to be cared for. So for instance, if you're taking care of a person that's a trans man, so their sex assigned at birth would have been female, but they live as a man, a trans man, they may retain such things as a cervix. But if they're not out to their provider or their provider is not asking them what their sex assigned at birth is, what their gender identity is, you may not know they have the cervix. And if you have a cervix, regardless of what is going on, you need to have cervical cancer screening. So that's where a lot of this relies on, is the just need to really know who the patient is to make sure that we're screening them properly, we're giving them the right tools so they can have the best optimal health.
I mean, that's a great example. And I think it, again, brings it back the importance of knowing the information that's important and that guides the best quality care that we can provide. And so being able to explain the rationale, the need to know that information and how it can inform the care we deliver, I think that's important for nurses to be aware of as well. So thank you for providing that example. Before we move on, let's do one more definition. Can you help expand the acronym of the LGBTQ plus and help elaborate on how it's used in healthcare?
There really is no right acronym. It definitely changes over time. I think the most common accepted one right now is LGBTQ plus. That stands for lesbian, gay, bi, trans, queer, and the plus. And the plus encompasses all the different identities there. I think queer can be a difficult term for some people to really understand. For some of our older LGBTQ or LGBT people, they may find queer offensive. But a lot of younger people have really reclaimed that term. So right now we're using queer as the umbrella term. So the queer umbrella, the queer culture, the queer people, queer studies, queer health, and then have all the different other areas within there. So you may also see, like at my job, we have a clinical advisory council, and we're considered the LGBTQI clinical advisory council. And what the I for us stands is intersex. And we talked about that a little bit earlier, but intersex people are people that are maybe born with both sex characteristics, both sex chromosomes, hormones, etc. So the acronym is always changing. And I think it changes because people are becoming to know themselves more. There's more available options. People are more open about things. People are seeing themselves represented more in the media, and it's talked about more. So it's just another way that people are becoming more comfortable.
As we talked about as we were starting our episode today, if you're not sure what acronym is the right one to use, you can always just ask. Whatever the audience is, or if you're talking with an individual patient or a member of the community, you can ask, what acronym do you typically refer to, or what do you prefer? So I think it's important to always stay curious and open to the idea, as you mentioned, that there's not always one right answer, but just being curious to find out what is preferred by the patient or the community that you're talking with at the time.
Yeah, and I think it's also important to know when you ask people, say you're asking SOGI data at your institution, be very careful that you're not asking it only to targeted people, to people you're assuming are part of the LGBTQ community. You want to ask that to everyone. So you want to make it an opportunity to ask everyone the question, not just certain people. So when certain people will say, well, why are you asking me that question? You could say, well, we ask that to every patient that comes here because we want to make sure we're taking care of all people. And it's just something I think that's important to note.
I think that's a great point to make. It kind of leads me into a little bit into our next question is, are there examples of the best language or phrasing to use when we are asking patients about that SOGI data? So their sex assigned at birth, their sexual orientation, gender, things like that. How can we start that conversation?
Yeah, I think it just, it's very a matter of fact kind of answer, like thinking of it as a demographic. Yes, it is a person's identity and who they are, but we want to make it a very normal thing to ask that. So, when you're asking, what is your sexual orientation? You're just giving those options: straight, hetero, gay, lesbian, bi, and then other, or prefer not to answer. I think that's another question. And another thing is, it is important that these are like a self-questionnaire that patients can answer, and that they're always not mandatory questions that people have to answer. And then when you're asking about gender identity, thinking about, you can say man, woman, non-binary, trans man, trans woman, other. Those are really the common terms right now. And then also note, I think it's something that, for listeners to think about, realizing, as we talked about earlier, sex and gender are two different things. So sex and your gender identity are two different things. So if there is sex or sex assigned at birth, it says male, female, other. When you put gender identity, try and make sure that doesn't also say male, female, other, because then patients may get confused of like, what are they really asking me? Are they asking my sex assigned at birth? Or are they asking my gender identity?
Those are some great tips. And it makes me think my clinical practice was predominantly in the outpatient setting. And so a lot of the times, this is the kind of information that we gather when a patient's being roomed, right? They're put into their clinical exam room or their infusion chair. And so sometimes our medical assistants are the ones doing that work for us, not for us, but with us as part of our team. And so I think that it's important that all of the great information we're learning today on this podcast, hopefully we'll turn to our colleagues, our nursing assistants, our unlicensed personnel that are helping be part of that healthcare team. And we can share what we're learning today because, it takes all of us to do this work and to communicate consistently and effectively so that we can make our LGBTQ plus patients feel included and feel like they're welcome in our healthcare settings.
I agree.
So let's transition a little bit now to why it's important for nurses to use supportive language and to help their patients feel comfortable and included. And we know members of the LGBTQ plus population, they may hesitate to engage with their healthcare providers, especially if they feel unsure if they'll be welcomed. And so can you elaborate on the history of that mistrust and, what can we do to overcome that?
You think about it, there's a lot of history with mistrust of the queer community and healthcare providers, from when basically homosexuality at the time was considered a mental disorder and was treated in various ways that, would really be considered barbaric now. And the way there's been a lasting impression of the AIDS crisis that happened in the 80s, where many, over 500,000 people died of AIDS, predominantly those being gay men and trans women. And really the government, the medical, didn't really acknowledge it. Back in the day, they called it the gay cancer, gay plague. There wasn't a lot of funding, a lot of care, a lot of research put into that. And a lot of that was done by grassroots efforts. So it starts to build this mistrust that if I go into these establishments, I'm going to be treated badly. I always thought this was a thing of the past. I have fortunately, I myself, I don't think I said in the beginning, but I myself identify as a gay man, and I have never been treated badly in healthcare. I've always been treated really well. But I went to a National Health Institute forum about LGBTQ cancer care not too long ago. It was a virtual thing. And one of the panelists was a patient, and she was a lesbian Black woman. And one of the things she said when she was talking, she said, I expect to be treated bad. And this was 2023. And to think that people still think that is just something to notice. So if you think about mistrust in our providers, it is not the community's duty to gain the trust from the providers. It is really our duty as providers to make it a safe space so the patients can come to us and get care. And when you have mistrust and when you have fear of going to healthcare providers, it's just not going to do well for the community. They're not going to get screened. They're not going to get diagnosed early. They're just going to have poor outcomes based on cancer outcomes and how that goes.
Absolutely. I think that you made some great points there. Certainly, I think the history is always painful but necessary to unpack. I think to take a long, hard look at kind of how things used to be. And maybe we have made some progress. Hopefully, we have. And it sounds like your experiences have been mainly positive. But I do think that it's probably very driven by the community and the environment that you live in. And not all parts of our country are likely as accepting and progressive. And so, like you said, I think we as individual clinicians, we are responsible for trying to change that for our patients in our community. Maybe we can't change the whole community, but we can start with ourselves and our places of practice and doing what we can to make sure that patients know that when they come to see us for their care, that we will treat them with respect and we will meet their needs the best that we can. And so I think that's really important for listeners to take back to their teams and their institutions to find out, what is your organization doing to help promote a safe environment for all of their patients?
It's always made me so proud. I've been a nurse for almost 20 years now. Actually, yes, I'll be graduated 20 years this May. But, we're the most trusted profession and patients really get in tune with us. And if they feel safe with the nurse, they really start to feel safe within the healthcare system. And you can really tackle a lot of that feelings that patients can have and the worry that they have by just being there for the patient, by really acknowledging who they are, acknowledging who their family are, who their caregivers are. And it's something that is so powerful as nurses that we sometimes forget we have that power.
Absolutely. And be their advocate. So if they do trust us, if they have formed that bond with us because they feel like they can trust us as the nurse, and we learn that information and we realize maybe they've not fully shared everything with the actual physician or advanced practice provider, then we become that advocate and we become that bridge to make sure that that information gets shared for the right reasons, and that you have to let the doctor know, by the way, I learned this. That means we should be screening for this, or we should be making sure that these tests are part of their plan of care. And so it does become important for us to keep our ears open, be respectful of what they share in confidence with you as the individual nurse, but be able to explain the importance of what that information is to their overall plan of care and how that can impact their health. And so again, just being that bridge and helping to hopefully extend that trust to the entire healthcare team and not just keep it with us as the nurse.
Yes, I totally agree.
So you mentioned briefly, but I'm wondering if you have more details about, the impact on screening rates for LGBTQ patients if they feel like they can't trust the healthcare system and so they don't have regular healthcare and regular screenings.
Yeah, so if you look at the body literature out there, it is lacking in LGBTQ cancer care in general, just like many other different groups. But what really is shown is that members of the queer community are screened less often. And that could be from a multitude of reasons. Some of the reasons are some providers may think that patients are not at risk. I have heard providers in the past, OBGYN or primary care, think that a lesbian woman, so a woman who has sex with another woman, is not at risk for getting HPV or is not going to have a child. So they don't need to get cervical cancer screening. They don't need to get pap smears. Just making these assumptions. So that's putting these patients at a default risk. And then when you look at, there are definitely some vaccinations, especially for men who have sex with men or gay men, meningitis vaccines, hepatitis A, hepatitis B, meningococcal, things that are just proactive that they should have, which is recommended. But if they're not out to providers or providers not asking them, they will lose out on these certain vaccinations. So in a screening sense, oftentimes queer people are screened less for cancer. And unfortunately, because of that, they're usually diagnosed at later stages. So we all know we want to get cancer precancerous stage 1. Queer people often diagnosed at stage 2, 3, and 4. And that just is putting us at a deficit, which just leads to lower rates of cancer survival compared to the other populations.
And I imagine that the idea of screening and making sure our patients are getting the right screening can be slightly more complex when we're talking about our transgender patients that have even perhaps had gender affirming surgery, just trying to make sure we understand what risks are still there based on the surgery that they may have had and how that needs to guide their care moving forward.
I remember I was working, I took care, I was involved in we had a trans woman who had transitioned many years ago, had gender affirming care, but she had a history of prostate cancer, a familiar prostate cancer, which was also putting her at risk genetically because her sex assigned at birth was male. Her birth father had prostate cancer. Her grandfather had prostate cancer. And it was really this new era of like, what do we do for this person who really no longer has the prostate, but still has this long history of family prostate cancer? It's something that we definitely need to think about. And this is often going to come up more and more as time goes on.
That also just made me think of, it doesn't even require the surgery is important to know about, but if patients who are transgender are taking hormones, just having that on their medication list, making sure we understand what those medications are, how they take them, what are the side effects of those, will that interact with potentially cancer treatments if they have been diagnosed with cancer? There's just so many things to consider and be sure that we're asking the right questions so that we can make sure that we have that complete record of their care.
Yes, and making sure that when people are really working with their trans care doctor, their endocrinologist, the folks that are really helping them to partner with them, just like you would their renal doctor, their diabetic doctor, their cardiologist, making sure that we're really talking to them when planning out their cancer journey care.
So how can oncology nurses work to help improve their own healthcare setting or their individual practice to support LGBTQ plus patients with cancer?
I think I said this on the last time I was on the podcast. Look at what internal resources you have within your institution, because oftentimes we work at these large institutions and there are things that we may not know about. So look in there first and just see if there are any trainings offering. I myself am one of the co-leads of our LGBTQ employee resource network at my job, which has been super helpful. If there's one of those, engage in one of those to see. You don't have to be a member of the LGBTQ community. You can be an ally. We would be nowhere with allies. So they're a very important part of this journey, this work as well. So I think that is an important step to look at. And I think also any kind of training that you can get that is just a very basic kind of high level 101. What are terms? What are definitions? What does this mean? Any way you can incorporate that into your orientation, your annual review modules, your onboarding, anything like that. Here where I work, we started doing what we call safe zone training. And we do this currently. We do it now for every new nurse that starts and every new APP. And we're expanding. We do within other departments across the organization as well. But Safe Zone is, and I think there'll be a link in the episode description, but it's a national organization. They offer free modules, free PowerPoints, free templates, basically everything there, templates that you can make for your institution and put your own spin on it and really get some of that core information that you need. That is probably one place that I would start first. Great, great organization. And then another one is the HRC, so the Human Rights Campaign. So they are a human rights campaign is a organization that looks into LGBTQ rights across the US. And they have a special division about healthcare equality index leaders. And what that is they designate certain institutions HEI status. And you have to meet certain criteria, certain points, and you get designated as an HEI institution, an HEI leader. But they offer a lot of free trainings within their module, and it's all free. It's almost like you log into their system. You get all these different courses. You get some CEUs for it, I believe, but you can get your institution registered with them, and your institution gets a unique facility ID. And then any person that takes these HRC trainings, your organization gets like a credit for it, which helps to HEI status.
Wonderful. My takeaway from that is hopefully your institution has some information, has some programming, has a committee, has something to start. If you're just on this journey of learning more and trying to become more informed, hopefully your institution has resources. But even if they don't, the resources are out there. We as individual clinicians, we need to take that responsibility as just part of our profession of nursing to teach ourselves what we don't know. And as you've mentioned, and we'll include a lot of these links in the episode notes today, there are some wonderful resources out there. And so we should feel called to make sure that we are prepared and we are informed so that we are providing excellent care to our patients.
When I started with the Safe Zone, so there was a small group of us that were kind of like in the know. Many of us were a part of the community. We were part of the ERN. We were going to the trainings. And I remember at the time, my colleague Ruthie Gordon and I, we were on the education committee of our ERN. And we were like, how can we expand this beyond just all the LGBTQ people? Like, we want to talk to everyone about this. And we actually expanded Safe Zone training across the organization. And we actually had a podium at ONS. This is probably 7 or 8 years ago. We presented at ONS and talked about expanding the rainbow and presenting Safe Zone training at a large institution. So it's something you can do. We did it from a very small scale. And now I think we train over, 1,500 people a year at least, which is really incredible.
That's amazing. And I hope that encourages people to be brave if they are not part of the LGBT community, but want to become an ally. I think that there's, as you've said, there's room and there's a welcome invitation to learn more. And it's okay if you stumble and you say the wrong thing or you make mistakes, as long as you learn from those mistakes and you can share what you learned with others. So I think it's really important for nurses to really take that responsibility if they feel like they don't know what they need to use these resources that we'll provide some links to start that journey of learning more.
Absolutely. And one thing I just want to speak to all allies. I have talked to many people and they feel, well, I can't do a Safe Zone training. I can't talk about LGBTQ issues. I'm not part of the community. And I always combat that and say, well, I don't have cancer. I have never experienced that, but I teach about cancer. I take care of people with cancer. And I think we all have that. So being an ally means you're coming from a place where you know what issues are going on. You stay up to date about what is happening in the world. And just because you're not a part, you identify as part of the LGBTQI doesn't mean you can't teach about what's going on. So just wanted to make a note on that.
I love that. I love that example too. Of we all treat cancer and we haven't all had it. So it's not a barrier to being part of the cause and helping to promote that everyone learns more and is better equipped to care for all patients. So I love that. So one situation that I know comes up, unfortunately, is when maybe oncology nurses are caring for patients, advocating for their patients, but maybe not all of the other healthcare providers on the team are on board. And so maybe they're resistant to using the patient's preferred terminology, like their pronouns or their chosen name. What recommendations can you give on nurses who are in that situation so they can advocate for their patients?
That's really tough. And I know that happens. I just want everyone to know when someone tells you their name or their chosen name and their pronoun, and someone purposely goes out to either misgender them or what they call dead naming. Dead naming means someone has a name and they choose a new name. So their legal old name is really their quote unquote dead name. And there's this term people use called dead naming, where people specifically use their old name as a way of kind of sticking it to them and jabbing them. And it really is a form of violent, abusive behavior. And it really makes people not want to seek out healthcare. It will make patients feel they don't want to be there. They want to leave. They're more, maybe they'll sign out AMA. Maybe they won't listen to the discharge instructions. Maybe they won't call if they're not feeling well. So I think you really have to look to see what your institutional policies are on this and really be brave and report people when they're not following institutional guidelines of how you respect patients.
That's good advice. And again, if your institution doesn't have policy that guides that type of behavior, that's where you start your advocacy right there, is to make sure that all of these important facets of patient care have a corresponding policy to back them up so that there is something to support when people are out of line and not doing what should be done. So that's important. Thank you for that recommendation. All right, Beau. Well, thank you so much for all of this great information. It's been a great conversation. I hope our listeners have learned something new or have something new to consider of learning more or sharing with their team. So as we wrap up our episode today, I do want to ask just a few final quick fire questions. So to start this off, what are some common misconceptions about caring for LGBTQ plus patients?
I think a common misconception is that you can tell who's LGBTQ, that you can assume who is this and who is that and what people are. So I just wouldn't make assumptions about people. And I think this goes for all people, right? Like this is not just an LGBTQ issue. This is just a patient issue. So oftentimes I give this talk and I talk about there are many married couples now that aren't having children and they're choosing to be childless, and people make assumptions about that. Or there's people that want to be single and people will see a man by himself and just assume he has a wife, or see a kid and say, where's your mom and dad? The kid may not have a mom and dad. Yes, the kid could have two dads. They could also have their grandparents raising them, or a foster parent, or a sibling. So don't assume things about patients. Ask about our patients. Learn about our patients. Don't ask yes or no questions. Ask these open-ended things to really get to know people.
I love that. I think the open-ended question is very valuable. Kind of along those same lines, my next question, how should nurses evaluate their own implicit bias when caring for LGBTQ plus patients?
I mean, that's a hard question. I mean, we all have bias, right? We all have conscious bias, unconscious bias. I myself, still to this day, if I see a man and a woman together, I assume they're married. That's just my assumption about them. And I shouldn't assume anything about people. So I think it's just recognizing that. I think meeting queer people, becoming friends with any coworkers that are queer, just to learn about them and realize that, gay folk are not any different than any other people.
They're just people. They're just people who want care.
Exactly. We want the same things just as everyone. We want to come to work. We want to take care of our patients. We want to go home to our loved ones. We want to be able to share what we did on the weekend or what we're doing on vacation, just as you may want to share about what you did with your spouse and such. So I think it's just being aware of how things can be hurtful when they're said. Just like I said before, this goes beyond the queer people, but go with everyone. But just really thinking about these assumptions that we make about people and just knowing that gay people are normal. There are many gay people in the US. So there was a Gallup study done, the most recent from 2022, and 7.1% of the US population identifies as LGBT. That's a lot of people. And a lot of younger people are identifying as LGBTQ. Generation Z, Gen Z, which is the younger generation, over 20% of Gen Z is identifying as LGBTQ. And a lot of people think that Gen Z is this TikTok generation. They're like only having fun and doing all this stuff. Like, no, they're graduating college. They're becoming our colleagues. They're our patients. They're people we work with. So it's just something to think about. Like, there are gay people everywhere, queer people everywhere. They're a part of every facet of everyone's lives. And they're really here to support and be advocates for the community.
I love that. And kind of back to your first response, and even if you know and confirm that your patient is part of the LGBTQ community, then you can't assume that you know what they need and want, because every individual is unique. And so it's still the nurse's responsibility to ask those questions, be curious, and humbly try to inquire about, what is your culture like? What is your home life like? What do you need? What kind of care can I provide that meets your needs?
Yeah, I mean, it's so different because even myself, I'm like in my early 40s and I am married to my husband and we don't have children. We're not planning. We have many gay friends that are married without kids. We have many other gay couples that are married with kids. So there is no right way to be gay. So it's very different depending on who you're talking to. So I think there's no assumption you can make. Well, if this person says they're gay, this means X, Y, and Z. It doesn't really mean anything. So you really need to make sure and dive into like, what does that patient need from an individualized care point?
What's something about this topic that's not often discussed, but you wish people knew more about?
There's a lot of LGBTQ people across the US. 7.1% of the population is identifying as that's millions of people. And I think when you think about this, one thing that people assume is queer people only live in big cities. There's this misnotion that gay people only live in New York, Chicago, Miami, LA, San Francisco, but most gay people live outside of all of that. So all across the world, all across the US. So they're really within every area, every community. There's not a community that doesn't have LGBTQ people. And I think it's just important to know there's a lot going on in the US right now. There's a lot of anti-LGBTQ legislation, and it is really scaring a lot of queer people. And it's making a lot of queer people very nervous of what could happen and about what holds in the future. So I would just say if you do have queer friends, queer coworkers, and there may be times that people are a little on edge and stuff, I would just show them some grace and maybe some understanding of what they may be feeling inside. Because at times myself, I have felt very fearful what's just going across the nation.
I think that's a great point you bring up. I would encourage everyone to understand, a lot of this is local legislation at the state level. And so be aware of what bills are being floated through your own local legislation and understand what is it really saying? And do you agree with that? And what can you do to show what you think? Do you support it or not? How can you be involved to make sure your voice is heard? I think it's become even more important to me over the last several years of just the power that local politics has. And we get so focused on the federal level, and that's important too, but so much can happen at the local level and that we certainly have a little bit more proximity to. So become involved, be aware of what's going on, and use your voice in a way that aligns with your values to make sure that your voice is heard.
Yes, for sure.
Final question. What are some additional resources, whether it's training or education for oncology nurses, or maybe for patients or providers, if they need to learn more about the LGBTQ plus patients with cancer?
I know we had mentioned the HRC stuff before and the Safe Zone training before. There's a really great organization, the Fenway Institute. They have a plethora of modules, of talks, of webinars. They host many events. They go beyond just cancer care, oncology care. They really go on screening, health maintenance, hormone replacement, gender affirming care. So there's a lot there. The Fenway Institute is wonderful. You can get a lot of information there. And then also there is a national organization, GLAMA, the Gay Lesbian Medical Association. They have a national conference and they do a lot of advocacy and a lot of information. And actually, there is going to be an LGBTQ cancer care research conference here in New York in October that I know some of the colleagues are going to be involved in. So there's a lot more out there if you want to get involved. We actually need people to do any kind of research, papers, articles, anything to really amplify these voices and work. So I think it's a huge area that if you wanted to get involved, there is space for everyone in it.
That's wonderful. Those are some great opportunities, and we'll be sure to keep those links in the episode notes for today's episode as well. Well, Beau, thank you again for all of your time and information today. Do you have any final comments you'd like to share with our listeners?
Just remember, LGBTQ people are patients. They want just what everyone else wants. They just want to be treated fairly. They want to be acknowledged, treated with respect, and they really want to be cared for. And really to care for the queer community, you really have to know who they are. And that will really service the patients well, and it'll really make you have a better relationship with your patients.
Wonderful. Thank you so much for your time today, Beau.
Thank you so much.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.